behalf of Adley Oncology, I would like to welcome Dr. M.B. Agrawal and our guest speaker, Dr. Laura Michaelis, with all the panelists and the participants. So, with your permission, I would like to give a small brief about the Adley Oncology. Adley Oncology is one of the fastest growing company in India. It's dedicated to on cancer treatment only. Okay, the slide is not moving, but although I would like to inform that, and I am pleased to inform that Adley has got the Anvisa approval with PICS approval. So we are going to expand ourselves in the international market itself. This is not the last. One more information that we are going to launch nilotinib and eltrembopag also very soon. So these are the things, these are the new improvements about the Adley Oncology. One more thing I would like to say that we always work on patient's first approach. We work for the patient compliance. We work for the patient benefits, patient education, and we work for the affordable medicines. That's why we are leader in many hematology products. For example, Carfimib, Bidan, MDSO, that is azacitidine oral, MDS plus, etc. So with this, I would like to thank and I would like to thank Dr. M.B. Agrawal to make us the part of this webinar. Thank you, sir. Now I hand over the session to Dr. M.B. Agrawal. Yeah.
Thank you, Prashant, and thanks for the news that you're coming out with generics of eltrembopag and nilotinib. The patent is getting over in a month or two, so that will definitely make life of our patients very easy. So good evening to one and all. Our guest speaker today is Dr. Laura Michaelis from Milwaukee. She's going to lecture on better alternatives to 7+3, for whom, how, and why. This webinar is brought to you by Mumbai Hematology Group, supported by Adley, managed by Perfect Square. I thank Mr. Ashutosh Shukla and the team from Adley Oncology, Mr. Yash Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, a guest speaker, Dr. Laura Michaelis from Milwaukee, all our discussants who are themselves eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening or afternoon or morning, depending upon which part of the world you got plugged in. Tomorrow morning at 11:30 a.m. Indian Standard Time, we have Dr. Fadi Fakuri speaking to us from Switzerland on atypical hemolytic uremic syndrome. If you're interested, you can log in. Our discussants this evening include many important persons, and they are put up alphabetically here. Just to introduce them briefly, we have Dr. Ramesh from Madurai, Dr. Reshma Roshan from Srinagar, Kashmir, Dr. Roshni Pandey from Jabalpur, Dr. Saikat Datta from Bhopal, Dr. Sanjeev from Lucknow, Dr. Shilpa Prabhu from Bangalore, Dr. Siddhesh Kalantri from Nashik, Dr. Suman Mittal from Raipur, Dr. Sunu Seriak from Thrissur, Kerala, Dr. Sushil Selvarajan from Vellore, Dr. Varun Bafna from Kolhapur, and Dr. Yoga Lakshmi from Hyderabad. Let me introduce our guest speaker for this evening. She is not a new person for you. She was in Mumbai a few years ago, and many of you attended her wonderful lectures that educated us in the field of acute myeloblastic leukemia. She also done webinars for us during last 3 years, and today she is back with us. And I'm sure that this year we will be able to invite her once again to Mumbai. She is Chief Professor, Department of Medicine, Division of Hematology and Oncology at MCW, that is Medical College of Wisconsin, Milwaukee. 23 years ago, she graduated from Howard Medical School. She completed her internal medicine residency at Brigham and Women's Hospital in Boston. She received the Arnold Dunn Award for Compassionate Care in the Practice of Medicine during her residency. 2003, she relocated to Chicago, where she completed a hematology-oncology fellowship at the University of Chicago. She served as an assistant professor of medicine and program director of the Hematology and Oncology Fellowship Program at Loyola University Medical Center before joining MCW. She has specialized in acute and chronic leukemias, myelodysplastic syndrome, myeloproliferative neoplasms, bone marrow failure syndromes, and other myeloid disorders. At the net, this is the quote she has put up. Our mission in the leukemia program at MCW is to deliver superb care in a compassionate, individualized manner. We work hard to maintain active and innovative clinical research program, always with the goal of providing truly superior care to all our patients. And that probably sums up what her goals are. So today she will speak to us on AML, better alternatives to 7+3, for whom, how, and why. I'll stop here and request her to share her screen and deliver the talk.
Dr. Agarwal, thank you so much. I'm thrilled to join you, and I'm hoping to be able to share. Right, how does that look?
Perfect.
Good. So I'm thrilled to be able to be here. This is an exciting time to talk about acute leukemia, and I think it's going to continue to be. And I just want to say how thankful I am. I always feel so warmly welcomed by your group, and I'm the amount of topics you guys cover, and also the incredible questions. This is a really unique thing in the world to be able to do this, and I'm thrilled to be here. So thank you very much. So as Dr. Agarwal said, today I'm going to talk about better alternatives to 7+3, but I want to put a little bit of caveat on this word better, and that's because better really implies that we've compared them in a randomized way, and I don't know that that's where we are just yet. We're getting there, but better really requires a one-to-one comparison. We're still going to talk about alternatives though. So these are my disclosures. I'll be discussing off-label use of products, but I'll try and discuss that. I'll try and bring that up at the time. So for this audience, I don't need to be too, I can be a little bit general about the demographics of acute myeloid leukemia. The two things I always emphasize is that this is a disease of older individuals. Currently, the median age of diagnosis is about 68 years, and there's about 80,000 deaths per year globally from this condition. And you can just see that this is about the same 5-year relative survival. This is the 5-year relative survival of 2008 when you just look at the years from 2012 to 2018. But that is better than we were about the 5 years previous to that, and even 10 years earlier than that in 2000, that 5-year relative survival was about 18 to 20%. So a lot of the increased overall survival that we've seen is from better supportive care, especially with better treatment for fungal infections, better long-term survival from stem cell transplant, which in many cases is the curative option that we have. And I think soon, if we look at this, then 5 years from now, we'll begin to see real improvements because of therapies for older individuals that are easier to tolerate. So how can we really move the needle and change our outcomes to make people healthier and to allow them to live longer? When we look at a sort of 30,000-foot view, you can improve the treatment of myeloid leukemia and relieve the suffering of patients, in my opinion, in 3 fundamental ways. First, we need to improve our induction therapies so that they are safer, so that they target the most primitive clones of disease. Second, we need to better understand resistance pathways. We need to prevent the emergence of subclones, and we need to be aware of hereditary or germline predisposition syndromes that make disease reemergence more common or that make treatments more dangerous. And finally, we need to avoid relapse, and that's by capitalizing on immunotherapy, for example, stem cell transplant. We need to understand when are we just controlling the disease and when are we curing it. And finally, we can't be preventing relapse with treatments that add additional toxicities to an individual. So I think clinical research can be categorized in any of these three compartments. And I find that helpful when we're thinking about whether or not to do a trial is where is this trial going to add value to the patient and improve the likelihood that overall we're going to change the outcome of this disease. So where are we now? If you think about the eras of the 1970s to 2000s, we had CR rates, for example, with 7+3 in a fit population of between 60 and 70% of complete remission. But of course, overall survival was highly variable. In a young person with poor binding factor leukemia, overall survival might be 60 to 70% with chemotherapy alone. But in a fit person, even if they were able to get into remission, if they had worse disease characteristics like complex karyotype or even some molecular mutations, that median overall survival was much, much shorter. And that's largely because of relapse, or because of measurable residual disease, which of course we weren't measuring in that time. I want to point out that we've had hypomethylating agents since the 2000, which were the standard of care for older, less fit individuals with typical complete remission rates under 20% and a median overall survival of less than a year in most cases. We're all aware that in 2017 in particular, there was a huge change in the way we treated FLT3 AML with the RATIFY study and the introduction of the first targeted agent for FLT3 mutated AML. We also saw the introduction of liposomal daunorubicin cytarabine in the form of CPX351 that year, and also a reemergence of gemtuzumab, the CD33 targeted agent, in combination with cytotoxic agents, again, not only improving complete remission rates, but improving overall survival. And I would say that the last 5 years have been the introduction of changes to individuals with less fit or less able to tolerate cytotoxic induction therapy. And this is where we'll spend the bulk of our conversation today. So in the older or less fit population, which I'm going to work on helping us define, we've seen the introduction of azacitidine venetoclax, as well as venetoclax plus low-dose cytarabine, and cytarabine plus glastigib, of course. And my goal today is to talk about when might I choose a regimen that was targeted versus a cytotoxic regimen, and what are the outcomes that we might anticipate. In addition, between this era, we've also seen the rise of targeted agents for IDH1 and IDH2 mutant disease as well. So I'm just trying to advance my slide here. Good. So it's always important to, in my opinion, to talk about these in the context of a patient. It's very, I think, presumptuous for us to think that the patients have the same values for their treatments as we do. But I do try and talk to the patient that the most important thing to begin with is getting the diagnostic right. And there's a few new developments in diagnosis that we should go over. So for example, in this gentleman who's 69 years old, has a history of hypertension and high cholesterol, he was a smoker between the ages of 20 to 50, which, as you all know, puts you at risk for acute myeloid leukemia, as well as other cancers like the renal cell cancer that he had 19 years ago, for which he underwent a nephrectomy. He has normal creatinine clearance. He presents with dyspnea, some night sweats, and then anemia, thrombocytopenia, and circulating blasts. And of course, the first thing we need to do is review that morphology. And you can see here the clusters of blasts, and notably these kind of cup-like indentations in the cells, which is sometimes a clue to the molecular mutation, although it's not always determinative. So once we've reviewed his morphology, confirmed that he has indeed acute myeloid leukemia, and we see that his white blood cell count is 13 with 27% circulating blasts, a platelet count of 76, and an anemia of 7.5. One thing we have to think about is, does he have acute leukemia by the new diagnoses? Now, of course, with 27% circulating blasts, he does. But I think one thing to review, which has come up quite a bit, is the newer sort of categories of acute leukemia that are evident from the ICC and World Health Organization diagnostic guidelines. As you all know, two recent publications were published in the last year or so. The World Health Organization new category of myeloid neoplasms, and then the ICC new category was also published. And this category is what the ELN criteria are now based on. There's a few important differences, which I unfortunately don't have time to go over. But I do just want to point out that in individuals with NPM1 mutant disease, by the World Health Organization criteria, you don't need a certain number of blasts to be considered acute myeloid leukemia with defining genetic abnormalities. If you have the translocation BCR-ABL or the CEBPA mutation, which includes both the biallelic and the BZIP mutations, you do require 20% blasts. But otherwise, the World Health Organization is agnostic on how many circulating or bone marrow blasts are necessary. That's not the case in the ICC definition, where the NPM1 mutation requires more than 10% blasts to be called acute myeloid leukemia. I think there's still a lot of work to harmonize these two together, but in general, in this individual, in AML with mutated NPM1, the blast threshold is different in the World Health Organization, the ICC. Now, with 27% circulating blasts, he meets criteria in both. But what we can do here is formally say that he has acute myeloid leukemia with a defining genetic abnormality. So the next question that also comes up is, do we have to treat this person emergently? And the truth is, well, I don't have time to go into the data, but there is emerging data that, especially in an older person, it's okay to wait for the full diagnostic material most of the time. Now, of course, you need to manage leukocytosis, you need to manage anemia, you need to make sure that you're not having intracerebral bleeding or any other kind of catastrophic care that requires emergent attention. But in a relatively stable person, as long as you keep this white count under control, you can usually wait to get your full diagnostic material, which may well be informative in your choice of therapies. So I want to take this opportunity to point out a great new review article that was published this month in the Lancet by Dr. DiNardo, Dr. Erba, Dr. Freeman, and Dr. Wee. And this article I thought was a beautiful review of acute leukemia and absolutely worth a read for everybody. And one of the panels from that shows what our expectations should be for the turnaround time of key findings for acute leukemia. And it also points out the importance of getting morphology like we did, and that's something you can get as soon as the patient gets to the hospital. Immunophenotype, which is not just important for diagnostics, but it allows the ability to follow a given phenotype over time, and it's very important for measurable residual disease in people that may not have molecular markers that you could follow with PCR or which are unreliable in PCR. In addition, sometimes that immunophenotype might be present even if certain clones with certain molecular subtypes are eradicated. So another important reason to characterize by immunophenotype. Cytogenetic analysis should be able to be turned around within 5 to 7 days. And if you're very lucky, and again, I think this is something we're all trying to get, molecular genetics by PCR, next generation sequencing for key actionable mutations. So NPM1, CEBPA, which both can define, especially in younger people, curative options. FLT3, which gives you treatment options. TP53 RUNX1 as AXL1, which may tell you that you don't want to give this person cytotoxic therapy. IDH and IDH1 and 2, which define therapeutic reach, and then also fusion transcripts that can be followed over time. So we've talked a little bit about the importance of diagnostics and the timing of diagnostics. I now want to move into risk stratification. And I want to emphasize that risk stratification historically has been thought about in terms of cytogenetics and molecular characteristics of a given disease. And that tells me about how vulnerable that disease is, importantly, how vulnerable it is to cytotoxic therapy. It does not, most of the time, risk stratification does not speak to whether or not this patient will respond or not respond and what their overall likelihood of benefit is from less intensive therapies. So that's an important thing to keep in mind. I think the other important key to risk stratification is to accurately and understand the frailty and comorbidities of your patient. And that speaks to the vulnerability of the patient. And there's often an inverse relationship between the aggressiveness of the disease and the frailty of the patient and their comorbidities. And that's number one, because age is one of the most important reasons why people develop AML, and the most important reason why the stem cell compartment is unable to contain or control that AML. So when we talk about intensive or less intensive therapy, we need to understand whether or not this disease, whether or not the treatment is going to harm the patient, and whether or not the treatment is going to harm the disease. And we have to think about that balance. So fitness assessment, or understanding whether or not a patient is fit, is very challenging. First off, many people don't routinely employ some formal fitness assessment, despite the fact that it's really an aid to choosing therapy. Second of all, it's often in the eyes of the beholder. So I might walk in and see a patient who to me looks fit, and I think, generally, yeah, this person can probably tolerate cytotoxic therapy. But if you ask their wife or their spouse, they may say, well, my husband really spends most of his time in bed or in the chair watching television. Or they might also bring up that his cognition is slipping and he may not be have a good enough memory or be able to weigh in on his therapy. So it really depends on who you ask. Certainly, the likelihood of being treated with intensive therapy declines with age, and the Swedish have done a good job of showing that even people in their 80s are only about 10% are likely to be treated with intensive therapy. And this was in a time period when less intensive therapy was not available. And yet we do know that age alone, not including fitness, does not necessarily make intensive therapy more dangerous. So the Ferrara criteria are what our current standard of care is. And when I use that phrase, the Ferrara criteria, I'm talking about individuals that meet one of these categories being considered too risky to give cytotoxic therapy. And this is from a paper in 2013, but generally it does say that over 75 may be too risky. And then these additional issues. Importantly, I want to bring up that item number 9, which says that any other comorbidity the physician judges to be incompatible, which often gives you as a physician an out. It says that in my medical opinion, this person is not a good candidate for cytotoxic therapy. So that that personal opinion that I believe this to be the case is one of the most important ways that we can sometimes give less intensive therapy to people who might not meet these strict criteria. I would say there's also a role for the geriatric assessment, and this is to inform initial decision makings, as well as when you are deciding to give someone cytotoxic therapy, to make sure you're planning for other interventions like good physical therapy or geriatric help, help with pharmaceuticals, that kind of thing, to make sure that when you send them home, they'll be well. I always quote this really nice study that was developed by Heidi Kleppen, looking at patients who were over the age of 60 who were slated to get cytotoxic therapy. And what she showed is that if you had a poor cognitive function at baseline, your overall survival was much worse than if you had a good cognitive function at baseline, based on the scoring that she did. So if you got cytotoxic therapy and your cognitive function was worse before you started, you were less likely to survive. Also, having low physical performance at baseline meant that induction therapy was less likely to benefit you. So I do think that an easy geriatric assessment looking at cognitive performance and physical performance, as outlined in her paper in Blood 2013, can add value to your decision making. Now, this has not been replicated in a multi-institution setting, and it doesn't tell us what would have happened to those individuals if they got lower intensity therapy. As a group, the National Cancer Institute and a group of cooperative groups are hoping to replicate this data, but in a randomized setting. So this is the fitness algorithm that I use. If the patient's over 74, I often will think about this patient in a less fit category and think about less intensive therapy. Now, a very fit 75, 76, 80-year-old, I might talk about cytotoxic therapy, but this is sort of one of my first categories. If that's not the answer, do the Ferrara criteria apply? If the answer is yes, then I move this person into a less fit category. If no, then I do a geriatrics assessment. Is that concerning for cognitive function or physical performance? If yes, I move the patient into less fit. If no, then I consider the patient fit and think about treatment in that way. So we've thought about risk stratification in terms of fitness assessment. Let's talk about disease characteristics. And this is what we currently use based on the European Leukemia Net to categorize what is favorable risk, what is intermediate risk, and what is adverse risk. Now, these have also recently been updated. A couple of things. First now, to be in the favorable risk category, you no longer need to have biallelic CEBPA, but it's rather where the mutation is, and it's in this BZIP region in-frame mutation. So that's something to talk to your cytogeneticist and molecular study patients about. The other thing to point out is that all FLT3 mutated disease is now in intermediate risk, no matter what the allelic burden is. And that reflects the use of FLT3 inhibitors in combination with cytotoxic therapy, being able to change the outcomes for patients with FLT3 disease. The other important thing is that some of the molecular mutations have been expanded. Now, this does not necessarily apply if people have favorable risk cytogenetics, but it does apply in normal karyotype or complex karyotype. And these mutations, which can be pulled up from next generation sequencing, are very important for categorization. So our patient is admitted to the hospital. He started on fluids, allopurinol, transfusional support. He's found on CT scan of the lung to have mild to moderate COPD from his prior smoking, and his FEV1 is compromised. And so this gentleman meets criteria for the Ferrara criteria. When I think about him, he is not fit for intensive therapy. We do not have an available clinical trial, and therefore, so if he's likely to be curable with cytotoxic therapy alone, I might think about intensive therapy for him. But with his lung capacity and his single kidney, he is not curable with cytotoxic therapy, and therefore we move into less intensive therapeutic options. And I want to now take a few minutes to talk about a combination I'm sure you're familiar with, which is the use of BCL2 inhibitor venetoclax in combination with the azacitidine or decitabine hypomethylating agent, which I think is appropriate if he were to have a FLT3 mutation. It's appropriate for somebody with an IDH1 or 2 mutation, and it's also highly appropriate for individuals who don't have a targeted mutation, and as we'll talk about, individuals with NPM1 mutations. So why would we think about BCL inhibition in AML? Well, preclinical data from the 2000s showed upregulated BCL2 showed an evasion of apoptosis, and that pre-leukemic cells, including the stem cell, were addicted to BCL2 in some capacity. There was a CLAGB study in the 2000s looking at an antisense oligonucleotide to BCL2 with intensive chemotherapy, but it was only with the advent of venetoclax use in relapsed refractory AML showing a response rate that it moved into the frontline setting. And of course, azacitidine is nonspecific, but does have some anti-MCL1 activity, which cooperates with the BCL2 inhibition, as well as having its DNMT3 inhibition activity. So the Viallier study looked at individuals with untreated AML over the years, over 75 or with comorbid conditions. Importantly, the modified Ferrara criteria means that people could not get onto this study unless they met the criteria, but they could not get on just because the investigator didn't think that they were good candidates for cytotoxic. So they had to meet sort of criteria 1 through 8, not number 9. But they also had to have pretty good creatinine clearance and adequate hepatic function. So they couldn't be too sick when they went on the study. As you know, the intervention was for azacitidine of 75 milligrams per meter squared, days 1 through 7, and venetoclax 400 milligrams for 28 days. And notably, people were not on azole antifungal agents for this, so the venetoclax did not get dose reduced. And then the comparator was placebo controlled with a 2-to-1 randomization and overall survival. You all, I'm sure, are well aware of the hazard ratio for survival that was published in 2020, which really changed the face of treatment for AML in the older patient population. With a median follow-up of 20 months, the control arm had the overall survival of 14.7 months. I'm sorry, the interventional for 14.7 months, and the hazard ratio for death was 66. And importantly, both CR and CRI are endpoints that have been linked to overall survival. So these are appropriate endpoints to look at in a clinical trial. And we saw, of course, that the AZA-VEN arm had a 66% CR/CRI rate, which is really important, especially if you're considering a now fit person, somebody who's gotten fit, whether or not that person could go to stem cell transplant. So, of course, an excellent new option. It's safe, but not risk-free. Interestingly, we have very little understanding of how this compares to cytotoxic therapy. There is a single institution database analysis that I've looked at a couple of times, which shows that the overall response rate in this unselected patient population, where, again, retrospectively, was somewhat similar, with an improved overall survival for the intensive arm, probably based on the fact that individuals went to transplant. And then when there's propensity matching done, the overall survival is actually a little bit better for the AZA-VEN arm. Again, this is retrospective, but we are planning a randomized study that will take individuals with higher risk, younger individuals with higher risk AML, and randomize them to AZA-VEN versus cytotoxic therapy. Now, there are some challenges to administration. You have to adjust the dose for azoles like posaconazole or voriconazole. There's some confusion sometimes about when to assess response. And then you also need to think about how to manage cytopenias, which can be quite significant. This is a very myelosuppressive regimen. I will point out that the supplementary material in the New England Journal includes the entire protocol, and it's not unusual that I go back to that protocol when I'm giving somebody AZA-VEN and think about how to adjust doses or how to dose reduce. It's important to remember that most responses occur relatively early. If a patient has not had a CR or CRI by cycle 4, they are not going to respond, and I will typically discontinue them at this point. If they've not responded by their second cycle, the likelihood of response is not good. And again, I start looking for clinical trials at that time. There's a very nice paper published by Keith Prats in a letter to the editor in 2022 about how to manage some of those post-remission cytopenias, how to dose adjust, and importantly, it's very important that after the first cycle, people are quite cytopenic. You want to do a bone marrow biopsy before you start cycle 2, because you may need to delay cycle 2 if someone's in remission, but their counts haven't yet recovered. So what about NPM1 mutant disease? Well, evidence shows that IDH2 and NPM1 mutants are among those with the most likely to have a durable remission. This is some of the molecular data from the early AZA-VEN studies that was published by Dr. DiNardo in Blood and has actually been updated. So truly, IDH2 and NPM1 are among those who you think that may have the best response of getting in remission and then staying in remission. Importantly, FLT3 disease was not well represented in these early studies, but I'm going to give you some data on FLT3 disease a little bit later. This was one of the other things to keep in mind, is that getting to molecular negativity is important, and those who are able to get into a molecular negative CR/CRI have improved overall survival. And Dr. Prats has updated this in the JCO in 2022, where here we're seeing individuals with their overall survival and duration of remission curves if they achieve CR, CRI, and molecular negativity versus those who do not achieve molecular negativity. And that's a reason to look at that flow cytometry on your patient. Is that aberrant phenotype gone? And if so, then you can really predict that this patient may have overall survival with even a flattening of the curve. And I think many of us have experience with patients who've been on treatment now for 2+ years in remission. And it is incredibly gratifying to see that duration of response in somebody in their late 70s or 80s to be able to live well with this regimen. So there's a manageable toxicity. There's a low 30-day mortality rate. Prolonged count recovery is, of course, common. And even the FLT3 subgroups in the later papers are showing a good CR/CRh rate in the 65% range. So what about the patient who's already been exposed to decitabine or hypomethylating agent? For example, this 78-year-old woman with a history of heart failure and diabetes who had a DDX41 mutation and was treated for anemia and myelodysplastic syndrome with oral decitabine. She responded for 19 months before progressing to acute leukemia with a new 7q deletion. What about this patient who's already been exposed to azacitidine? Well, you could look to the venetoclax and low-dose cytarabine group for her. How well could she respond to this? This study was published by Dr. Wee and JCO in 2020, in JCO and updated in Blood. And this shows what to do with venetoclax at a higher dose, 600 milligrams, as well as low-dose cytarabine, with low-dose cytarabine as the control arm. The overall survival was slightly better when they looked at the 18-month follow-up. The pre-planned analysis at 12 months did not show an overall survival benefit, but there was an improved hazard ratio for death after 18 months and an improved composite CR/CRI with this. I think the most important thing is that the lack of transfusion dependence in the combination arm for both platelets and red cells. So again, a patient who's transfusion dependent is tied to a clinic, has a much worse quality of life. And I think this is a very important endpoint, especially when we're talking about really control or palliation of a disease rather than cure. And this is the update that he published, that Dr. Wee published in Blood of 22, that does show an improvement in overall survival with the combination arm, although not nearly to the extent of patients that were treated with hypomethylating agents rather than the LDAC. You can see that the mutational status also appears to make a difference with those with P53 doing the worst. Unfortunately, if you've had a prior HMA exposure, and there weren't a lot on these initial studies, so our numbers are quite small, but the CR/CRh rate is less impressive if you've already been exposed. And I think that just points to the fact that that disease is likely more resistant. So I want to step now to mutations in isocitrate dehydrogenase. This is a patient of mine. She's 69 years old. This isn't her picture, but she had breast cancer treatment with radiation and presented with a higher white count of 50,000, 60% myeloid blasts, trisomy 8, and then mutation in the IDH1, as well as concerning mutations in BCOR and ASXL1, which go along with treatment-related disease. So her options for therapy being fit, where I could give her CPX 351 with complete remission rates in about the 50% range, which I would certainly do if I was planning to take her to an allogeneic stem cell transplant, because we know that CPX has its best overall survival in people that were consolidated with allogeneic stem cell. I could treat her with 7+3 plus an IDH inhibitor, but that's only really appropriate on a clinical trial at this point. And then what about less intensive induction? For example, using ivosidenib plus azacitidine, using venetoclax plus azacitidine, using ivosidenib alone, or using monotherapy with a hypomethylating agent. What I will point out is that this woman has adverse risk disease by the ELN criteria, which means her likelihood of getting into a complete remission and staying there with chemotherapy alone is poor. So that gets me back to, I determined that she is fit for chemotherapy. However, she's not likely to respond to cytotoxic therapy. So for this individual, I decided to treat her with a less intensive therapy. And I want to talk about the decision between using ivosidenib plus azacitidine or venetoclax plus azacitidine. So this data was published, this is published in the New England Journal by the German group, where they did a double-blind randomization of ivosidenib and azacitidine compared to placebo and azacitidine. This was 1-to-1 randomization. And what they clearly showed is that compared to a hypomethylating agent alone, ivosidenib does very well at improving the overall survival of patients with a median follow-up of about 15 months in this group of patients. But what we don't know is what about compared to our standard of care, which would be venetoclax and azacitidine. There's no randomized trial available to date, but there is an interesting paper that was published by Dan Pallier in Cancer Clinical Research, where he took evidence from the VIALE-A and from the phase 1b study and tried to sort out what this meant and the patient level data from the IDH1 mutated group in either one of those. And if we compare those 44 patients and think about them at patient level data, and again, this is a cross-study comparison, so I don't want to, this is usually not the right way to think about it, but it is just for our purposes here. If we look at the ivosidenib versus the venetoclax, just looking at CR and CRHs, the overall response rate here is 59% versus 52%, with the majority being CRs in here versus the majority here being CRHs. The overall survival here against azacitidine and against azacitidine, you could squint your eyes and say that it looks to be similar. The toxicities are a little bit different, though. We can see a higher amount of febrile neutropenia, a higher amount of thrombocytopenia in individuals with IDH1 and IDH2 mutations treated with the combo. And one of the nice things about ivosidenib is that it's not typically going to cause those same cytopenias. The differentiation syndrome, however, does happen with ivosidenib and sometimes can be higher than grade 3. And there is infections of grade 3 or higher, which is about 21% in the ivo arm and about 59% in the ven-aza arm. So I think we can say, and experience will tell us as well, the ven-aza does put people at higher risk for infections. So in this individuals, we could think about a CR/CRh rate of 18% with monotherapy, of AZA, 42% with IVO monotherapy, and then in the 50% range with ven-aza or IVO-aza. But I think in particular, one could think about fewer side effects in terms of febrile neutropenia and infections with the IVO-aza arm, knowing that we don't have randomized data. So importantly, you need to delay initial therapy until you know if this person has an IDH1 mutated. So it can only really be given in people who are safe to delay to find the answer, which may also show us a little bit of it skews the patient population a bit. And IVO-aza has a higher risk for differentiation syndrome, and ven-aza carries a higher risk for febrile neutropenia. In this patient, as I mentioned, she has a blast count of almost 40%. And so I would not start her on IVO-aza before a week or so of hydroxyurea to drive down her counts to the point where I wouldn't be worried about differentiation syndrome, for example. What about FLT3 mutated disease? Well, I mentioned before that the CR/CRi rate for FLT3 mutated AML, given the combination of aza-ven, is still pretty good. And this is from a paper by Konopleva. And you can see here that the ven-aza arm had a nice CR and CRh response, and that the use of aza-ven seemed to make FLT3 no longer a poor risk factor when you're thinking about less intensive therapy, which again speaks to the fact that our risk stratification systems ought to reflect the type of treatment that we're giving. There's preclinical data that shows synergy between BCL2 inhibition and FLT3 inhibition. So I think one of the things we'll see as we get further down the road is combinations of FLT3 inhibitors with venetoclax, as was illustrated by this Davar study from ASH of 21 and recently updated, and shows excellent CR and CRa rates for individuals with this triplet combination. I would say, however, I would never give I would not give a triplet off of study, and I only give gilteritinib plus venetoclax in relapsed refractory disease when I don't have additional options. This is the triplet combination, and I think this will read out formally later on. Maybe it's even at EHA this year. So finally, I want to say a word about cytotoxic induction therapy. I haven't spent too much time on that for time considerations, but I do want to emphasize that favorable risk cytogenetics, we typically add gemtuzumab to our cytotoxic backbone. There is definite randomized and meta-analysis data showing a survival advantage. In FLT3 mutated disease, there's a survival advantage of midostaurin, and then there's also recently published survival advantage to quizartinib combined with a cytotoxic backbone. I do not add venetoclax or an IDH inhibitor to my cytotoxic induction therapy yet because that hasn't been shown in a phase 3 data, but I do think that's coming down the pike. This is that DiNardo review paper I mentioned, and she has an excellent algorithm, I think, for thinking about when to consider additional therapies. I would point out, however, that any place there's a question mark and a star, it just shows that this is evolving, not yet standard treatment, but currently under investigation. So in the 70s, we had rapidly dividing cells. We then moved to targeted therapies. We now have targets that have actionable mutations. And I think we have more to come, including menin inhibitors, CD1 and CK9 inhibitors, and then immunotherapeutic approaches. We've made some progress, but there's a lot of work to do. And I also think that there's a lot of way to improve the care of our patients without necessarily coming up with new drugs, improving access, improving how we test, improving our metrics of success. And finally, I think that cooperation, rationalism, and innovation are really necessary. And maybe that's something that we've learned from the pandemic, is how to be more wide in our thinking and how to cooperate better. So I want to thank Dr. Agarwal and the organizing committee. I'm very happy to take any questions. And again, it's a thrill for me to be here.
Thank you so much, Dr. Laura, for updating us. It was wonderful. Enjoyed listening to you. We'll have some our colleagues here interacting with you. We'll use the raise hand sign. Until they do that, I have one question: whether in the era of all these agents, are the indications of transplant as the consolidation changing?
Yeah, so I think that's a fascinating question. So first off, there is more and more data that individuals that achieve complete remission, in particular complete remission with minimal residual negativity with less intensive therapies, do just as well post-transplant as those that are taken into transplant after cytotoxic therapy. Formal data on that is pending, but I do think that I feel very comfortable if I have a patient who's gotten into remission, in particular an MRD negative remission with a less intensive therapy, I feel very comfortable recommending transplant if that remission has now eradicated some comorbidities that made me hesitant to give them cytotoxic induction therapy in the beginning. I would point people's attention to a study. It was called the As Soon as Possible study that was presented at the plenary session at ASH. That says, look, you don't need to get people with AML and refractory disease into remission with cytotoxic therapy. You can take them directly to transplant. That is a tricky study to understand. I think there's better understanding coming, but that is only for myeloablative transplants. And really, the group of patients that we were referring to today are typically ones that you would take to a reduced intensity transplant. But in my opinion, remission with aza-ven is remission, and those people should be considered for transplant if they are otherwise fit to do so.
Thank you. Dr. Ramesh has a question for you. Unmute yourself.
Good, sir. Good evening, ma'am. That was a fantastic presentation. My one practical difficulty is like most patients who are favorable risk but unfit, who are put on azacitidine plus venetoclax. Those patients achieving complete remission and along with MRD negativity also, persistent MRD negativity. Like how long should we continue? How many cycles should we continue, ma'am? Like
yes,
if yeah, that is one practical question difficulty I face. Like patients also get financially drained out. Like if we keep on continuing, what is the full stop and where do we stop it?
I think that's a very good question. So the book says you don't stop, right? But going by the book, you don't stop. I definitely have had patients in that situation where the first thing I've done is get them into molecular remission, given them a few more cycles, and then stop the venetoclax and just continue the azacitidine alone. I also have a couple of colleagues who've done the opposite, where they stop the azacitidine and continue the venetoclax alone. Or what I've also done is just reduce the amount of venetoclax. So I have several patients, again, this isn't formal, this is just my practice. But if I have somebody who's been on therapy for, let's say, a year and is in excellent MRD negative remission, I might go to just treating them every 8 weeks and then decreasing the venetoclax to 5 days or 10 days. But of course, that's not supported by randomized data. I have another patient who is NPM1 positive, who got into remission and has now she had an intervening event and could not continue therapy because of something else that happened to her after a year. She's been off therapy for 2 years now in a remission. So again, these are anecdotal, but I think you have to weigh is this financially feasible? How long have they been in remission? And then you also have to think, how am I going to follow them? And what am I going to do if they relapse? Those are conversations that I have with patients. I tell them, look, we don't have data about stopping this, but you've been on this for, I don't know, a year. You've been doing great. I think it's okay if we taper back, et cetera. I do think that there's a role for more definitive consolidation so that these treatments don't have to be lifelong. One of the studies that we're looking at is taking people who have been on aza-ven, who are in an MRD negative remission, and then they'll be randomized to continuing aza-ven versus getting a time-limited cytarabine consolidation, which would then stop it. So hopefully those kind of studies will answer the question.
Thank you, ma'am. One more question is like any targeted agents for TP53 mutant patients, ma'am, like MDM inhibitors, any data on it?
Yeah, nothing that's really panned out so far. We are currently using a CD47 antibody called magrolimab in our P53 studies, in our P53 patients, but there is no randomized data to support that over aza-ven alone. That study called the ENHANCE, which is aza-ven magro versus aza-ven, is almost completed accrual and should read out in the next probably 6 to 8 months. And I do think that we desperately need P53 agents. But as you know, the APR 246 drug, which was very promising, did not meet primary endpoints in its phase 2 study. So I think really more to come on that. But that's really one of the most important drug stories of the next 10 years is how to attack P53 disease.
Thank you, ma'am. Thank you, ma'am.
You're
Thank you, sir.
Thank you, Ramesh. Siddesh, unmute.
Good evening, ma'am. Good evening, sir. Very nice presentation. I just wanted to ask, suppose we have a FLT3 positive AML who has gotten into remission with 3+7, and after that, we have also found a mud donor for that patient. So what would be your preferred bridge to transplant for this patient? 1 or 2 cycles of HIDAC, or just to avoid deterioration of general condition of patient, take this patient on azacitidine plus midostaurin and try to bridge for transplant?
Ooh, good question. I do not know the answer to that. I think one of the most important thing is if they are molecularly negative, then the conditioning regimen may be adequate. We don't know in somebody going to transplant, we don't know that additional cycles of cytarabine between a time of complete remission and transplant matters, but we don't have any data on whether or not more intensive consolidation matters between a time of CR with molecularly or with less intensive therapy and transplant matters. I think it depends on your conditioning regimen. I think it depends on how confident you are that they're molecularly negative. And also it depends on how beaten up they are at this time. There's always a chance with consolidation, even in our days of 7+3+ cytarabine, there's always a chance that that consolidation regimen may disqualify them for the transplant because, they, God forbid, get some kind of sepsis. So I think that's a tricky question. There's no data right now to answer that I could state confidently. I do think my experience with aza-ven at least is that molecular negativity, remission and molecular negativity as a destination, it doesn't really matter how you get there, as long as you get there and your outcomes for your transplant are better if you're able to get there somehow. So that's how I sort of think about it.
So like 2 or 3 months, you can continue patient on aza-ven if patient is molecular negative instead of giving HIDAC, because arranging mud will take some time.
There's always a chance that the disease is going to relapse on aza-ven. So if you're concerned that about the relapse risk with aza-ven, which is shorter, the relapse, if I remember correctly, duration of remission for FLT3 negativity is much shorter than for IDH2 or NPM1, right? So the relapse risk is higher. The CR rates are good, but the relapse risk is higher for a FLT3 positive. So you could certainly say, look, I'm worried about you relapsing while I try and get you this transplant, so I'm going to give you some cytarabine. that would not be, there's no protocol to do that, but that would not be unreasonable, I do not think whatsoever. If you look at the average relapse risk, and I would have to call back up the slides, it's in the Konopalava paper. If you look at the relapse risk for FLT3 and you say, look, the average risk is before I'm going to be able to get you to MUD, so we're going to do something else in that time period, I think that would be reasonable.
Yeah, thank you.
Thank you, Siddhe. Dr. Sunu?
Hi, Dr. Laura. Thanks very much for that nice presentation. Just a couple of questions mainly related to the dose of venetoclax. What dose of venetoclax might be you using in your regular practices? Is 400 full dose itself?
No, I only use 100, and that's because I usually give people the voriconazole as well. If I'm not giving somebody voriconazole because they couldn't afford it or something like that, then I'll go up to 400. Although I find that that's hard to tolerate. I will also tell you that by cycle 2 or 3, I'm usually down to 22 days or 21 days of venetoclax. And in my older patients, like I have a couple of patients in their mid to late 80s that I've treated with only 10 days of venetoclax once they're in remission, or even 5 days. So I definitely shortened that venetoclax. I will point you to the Keith Pratt's paper that I referenced, the letter to American Journal of Hematology, that has a very nice dose reduction. Now, some people, when they're giving the azole that starts with a P, not pantoprazole, posaconazole, they use even lower amounts of it. I don't. I use 100 milligrams of ven if they're on Vori or Posa.
And do you have any experience of using midostaurin as an FLT3 inhibitor?
Yeah, I use midostaurin. I've used midostaurin, of course, in the Ratify study, of course, with 7+3 backbone. And I've used midostaurin with azacitidine. There's some phase 2 data that has a dose for that and safety data for that. And then there's azacitidine plus sorafenib also has safety data. And we use gilteritinib with azacitidine occasionally as part of a clinical trial we have.
Practically, a couple of patients, many of the patients that I start with with venetoclax, most of them find it difficult to tolerate it. Cytopenias are extreme, and fatigue is also very extreme. Do you think that it might be reasonable also to start azacitidine alone and might be 1 or 2 cycles down the line, then consider adding venetoclax in those situations?
So I'm not going to recommend that except in the MDS population. So in high risk MDS, where azacitidine is approved, if I've given it to them for 2 to 3 cycles and they're not responding, I will sometimes ask the insurance companies, for example, to give me permission to give venetoclax in addition based on phase 2 data for aza-ven in a higher risk MDS. However, in AML, I am not, first off, you are the one with your patient and you can say, I really don't think that they're fit enough for aza-ven, which is it's not an easy therapy to take. It's less intensive and maybe less dangerous than 7+3, but not less dangerous than aza alone. So you can make that decision. But the efficacy of aza is so much higher when it's added to venetoclax. And that's because the activity is as an MCL1 inhibitor, not necessarily as a DMT3A inhibitor. So if I've sat down with my patient and say, look, the first 2 months are not going to be easy, but this is the way we're going to get you into a complete remission. If that's something they can tolerate, then that's good. And then I back off based on symptoms later on, back off to 5 days of aza, back off to lower amounts of venetoclax, etc.
Thank you.
Thank you, Dr. Sunu. Dr. Yogalakshmi.
Good evening, ma'am. Thank you for the excellent presentation. Ma'am, I have a doubt, like one of our patient is NPM1 mutated who presented with fungal infection at diagnosis. And so we were not able to give 7+3 at the initial diagnosis, and we started with azabine. After 2 cycles, she's MRD negative and CR and MRD negative, and now we are continuing on azabine. Shall we try the consolidation with HiDAC so that there will be a time-limited therapy for her?
Oh, such a good question. I don't know the answer to that. You could talk with her about the pluses and minuses, and talk with her also that we don't have very good data. We know that in people that are MRD negative who continue on this therapy, they do reach, there does appear to be a plateau where maybe they're not going to relapse. And in those patients, I think you could probably find some examples in case series of people whose treatment has been stopped and they remain in remission. Alternatively, you could say, we're going to keep you to that plateau, maybe 18 months, and then we're going to give you some cytarabine, but you don't even know if the cytarabine is necessary at that time. So it's one of those things where you're going to have to talk with them about what you don't know, and then make your best guess. I do think that there are people that it's probably safe to stop the treatment in, but I just don't know that I can confidently tell you who those people are.
Okay, ma'am. If we are treating a patient with alternative therapies other than 7+3 induction and HiDAC consolidation, is there any data about CNS relapses in these CNS involvements in these alternative regimens?
No, that's a great question. We do think that there's CNS penetration of aza-ven, and CNS involvement or extramedullary involvement at this point in time is not a reason for me not to choose aza-ven if I was otherwise going to use it. I would use CNS directed therapy as needed, like intrathecal therapy or radiation to a tumor bed if you had extramedullary disease, if you thought that was reasonable. But if you were otherwise going to choose azacitidine venetoclax for an extramedullary disease patient, I'm not sure that I would there's no evidence to say that you have to give them something else. I do think that there is excellent evidence for high dose cytarabine in extramedullary and CNS disease. So that might be something I would think about. But oftentimes, luckily, the elderly patient that you're, especially with pancytopenia, is less likely to have CNS disease.
Okay, ma'am. What to do if azacitidine and venetoclax fails in elderly unfit patients, but there is no targetable mutations?
Yeah, the data for that is very clear that that's a very poor prognostic sign. There was a nice paper at ASH out of the Mayo Clinic that the overall survival of individuals who are refractory to aza-ven and don't have targetable lesions have an extremely short overall survival. So that's a patient that I consider hospice for, or I consider palliative care with LDAC or Hydrea alone and transfusional support, unless there's a clinical trial available. That's a very difficult situation and one that we need to address as a community.
Yes, ma'am. Thank you, ma'am.
You're welcome. Thank you.
Dr. Suman.
Hello, good evening. So my question has been partially asked by a previous person. So I wanted to understand, if you are using azole with venetoclax, so which one is preferred and why? So voriconazole and or posaconazole, and why? Or we can choose either of them.
I don't have a preference. The posaconazole, I think, might be forgive me for not knowing my fungals quite as well as I ought to. I believe posa might have a little bit better coverage of certain molds. I can't remember if there's a randomized study between voriconazole and posa. We tend to use voriconazole. That happens to be what's more likely to be covered by insurance here, but I definitely have people on posaconazole as well. I will invite Dr. Agarwal. Perhaps he knows better than I do the differences between posa and vori.
No, we have been using posaconazole, one, because it's easily available, and two, because of some concern about the toxicity of voriconazole. And third, with posaconazole, the data that you had mentioned, the venetoclax dose is just 50 mg. So that makes it cost effective here. Here, venetoclax is more expensive than the antifungals.
So that's a great point. And yes, with the POSO, you know that the upregulation of venetoclax is even more. So if you can use just 50, I mean, that doubles the amount of venetoclax you can give your patient. So that's a great reason. And we all know that especially in older people, VORI does have this this hallucination sometimes that can happen. Individuals can have very bad dreams and sometimes even bad visions or hallucinations. So if that happens, I certainly switch a patient off.
Yes, Suman, any more questions from you?
Yeah, one more question. So I have seen people, they start using venetoclax on day 8 or day 9 of the cycle to reduce the toxicity. So what is your opinion about it? At least for
I mean,
initial.
sometimes you have to. You should, in somebody with a higher blast count, you need to go up slowly on the dose, maybe 50 to 100 over time. And you have to think about tumor lysis, although that's less of a problem in AML than it is in CLL, where you have to be extremely careful and your doses are higher. I don't know that there's any data that says staggering things helps. Also remember the toxicities to azacitidine don't happen the day you give it. They happen, people are feeling nauseous and their cytopenias start a week after they give it. So I don't know that staggering is going to help with the toxicities or the myelosuppression. If you have to do it, I don't think it's going to harm the patient.
Thank you. Thank you so much.
My pleasure. My pleasure.
Dr. Sekar?
Thank you, Dr. Lauda, for the excellent lecture. My question is, do you do anything special for AML with translocation 821 with c-KIT mutation, like upfront transplant or using of dasatinib?
So 821 and c-KIT?
Yes.
Yeah, so for a patient with 821 and c-KIT, I have some difficulty with whether or not I'm going to transplant them. I don't think at this time, I would only put them in intermediate risk. And I think I would debate transplant with them. I would tell them that the KIT mutation makes the 821 a little bit more risky, but I wouldn't routinely transplant them. And the reason I wouldn't is because if they relapse, their likelihood of getting back into remission, you could rescue them to a CR2 a little bit more likely than other intermediate risk. So it would depend on the risk of transplant. It would depend if they have a SIB donor or if I was going to do something else. But that is, I think, an extremely tricky recommendation to make. But I do think even c-KIT mutated 821 can get back into remission and get to a CR2.
Can you use dasatinib for those patients?
I don't know the answer to the data on that.
Another question is, in our country, most patients over 60 years don't get intensive chemotherapy 3+7 or high tech. So someone at the age of 60 or 61, 62 and having good ECOG, if relapse on AZA plus ven, what would be your recommendation? Like we can still give intensive therapy for them physically, they're fit.
Oh, certainly. I mean, if they're fit, data from multiple studies shows that it's safe to give daunorubicin and cytarabine and gemtuzumab, for that matter, if they have good risk cytogenetics, to patients over the age of 60. The alpha study was the alpha study was Dono 60, cytarabine 200, gemtuzumab fractionated for ages 50 to 70 and had excellent long-term survival for favorable risk and intermediate risk AML. And the Lowenberg study out of Germany showed you can give 90 milligrams of daunorubicin to people without an upper age limit relatively safely. They have to be fit, but age alone is not a reason not to give 7 and 3 if you think it's going to work and if you think it's going to be curative. So if I have an 821 patient, right, who's 65 and fit, I can give them, like the alpha study, 7+3 plus gemtuzumab and cure them without them needing a transplant and without them being on azaven indefinitely. that is absolutely something I'm going to think about.
Another question is FLT3 positive AML who are not willing or eligible for high dose chemotherapy. So your choice is as a plus VEN or as a plus FLT3 inhibitor. What's reflects?
So currently, for a FLT3, a less fit FLT3 positive patient, I will use, if they're not fit for chemotherapy, I will use aza-ven to get in, and then I may, if they relapse or I see signs that they're not in MRD negative, I may switch them to a FLT3 inhibitor, either with the AZA or actually with the venetoclax. That's off study, and that's something that I would do later. But I save the FLT3 inhibitor for my second line rather than in the first line. At least that's what we do at MCW.
And do you think that oral as a plus cedazuridine can replace IV or subcutaneous azacitidine?
I hope so, but I don't know the answer. So I think there's safety data on that brewing, and I do think the backbone eventually will be an all oral backbone, but we're not quite there yet. I do think that that's the wave of the future, though.
Thank you, ma'am.
My pleasure. Thank you.
Dr. Roshni?
Thank you for that excellent lecture. The first point was just to re-clarify that even in fit patients but poor risk AML, should we move away from 3+7 and give as a bridge to transplant?
Yes, so that's a very good question. And there's no exact answer. I think for poor risk disease like TP53, I'm hesitant to give induction chemotherapy and will often, first off, always prioritize a clinical trial. There are remissions that occur with 7+3 if you have a complex karyotype or poor risk molecular features. So certainly in a fit patient, I can talk about that. I just say that, our chances of remission are lower with this. Now, that being said, we also have lower chances of remission with aza-ven, so we don't actually have a great other alternative. In my patient, if a transplant is expected, so if I'm taking this person to transplant, even if they have poor risk disease, if they are fit, then I will typically talk about 7+3 or like CLAG-M or one of our other clinical trials. So I hope I didn't leave you with that impression. But poor risk AML, if transplant is a possibility, I still do consider cytotoxic induction therapy. If transplant is not a possibility, then I don't want to put that person through induction chemotherapy if I'm not aiming for a curative intent, in which case I'll try something less intensive initially.
The second is a case, he's a 48-year-old male, translocation 6'9". The MRD post-induction was 0.018%. He has residual ground glass opacities on the CT scan. So in this kind of scenario, should we do away with consolidation and just put him on azacitidine? He's not a candidate for transplant financially.
I don't know the
6'9".
answer to that. I don't know exactly what you should do, but I do know that what we've done in some of our patients who haven't had a complete response on day 14 or day 21 is transition them to aza-ven, and we have noticed an excellent response rate in that group. So I think if he's not going to transplant, I think it may be reasonable to think about that, but the trade-off, of course, now is you're putting him on indefinite therapy.
Yeah.
So you might want to try, depending on how bad his ground glass opacities are, you could try a second a consolidation cycle with cytarabine if you thought he could tolerate it, and then recheck the MRD and see if he's MRD negative, and then follow MRD negativity, and then if he relapses, start him on aza-ven.
The third thing is, of course, we are using posaconazole in an effort to reduce the venetoclax dose. But technically, how long do we need to continue antifungals with azafen?
Only as long as they're No, only as long as they're neutropenic. If they get into a CR and if they're in a remission and their neutrophils are good, then you can stop the antifungal, but you have to go up on the ven a little bit. So you have to balance that.
So going up is how much? What dose of
de-
venetoclax?
I would refer you to the Keith Pratt's paper, or you could, I mean, go up to 400. So it's possible that by giving them the posaconazole, you're decreasing the cost of their venetoclax, but the posa may not be necessary if their neutrophils are good. So that's a strange conundrum, which would take a little bit of Tetris to figure out.
And the last question is, what is the significance of this DMT3A mutation when it occurs along with, say, P53 or something else?
So DNM, what is it again? DNMT3?
Yeah.
Yeah, so that's a common spliceosome mutation, and it is associated with clonal hematopoiesis. I would have to relook at the newest ELN criteria to see if it was adverse, but it's definitely something that it may be clonal hematopoiesis and may not be part of the of the AML clone.
Thank you so much.
Thank you.
My pleasure.
Dr. Sanjeev.
Nice presentation, ma'am. I will like to ask you what precaution we should take when patient has been bring into remission by azaven compared to the 3+7 when we are consulting that patient with allotransplant. Any particular precaution with azaven?
I don't think so. There are some people who are looking at azaven maintenance post-transplant, but that is not yet standard of care. I think consolidation, one of the benefits of consolidation with a transplant is they could come off of therapy eventually. I think the standard precautions that you would take for infection and for graft versus host disease should be the same. I am not a stem cell transplanter, but I don't see anything that would stand out as particularly otherwise concerning.
My another question is if a patient of PMF has progressed into AML and with azaven he is not coming into remission, is there any point to combine JAK2 inhibitor azaven?
Yeah, so that's a very important question, I think. There is no published data on the triplet of ruxolitinib, ruxolitinib plus azaven. We don't think that I'm concerned that individuals with myeloproliferative neoplasm blast phase, NPM blast phase, may be one of those groups of patients that has an especially poor response to venetoclax. I do think that Rux is very beneficial in those patients in general. So I might use Rux AZA as opposed to Ven AZA rather than a triplet, right? That's a very cytotoxic triplet, if you think about it. I would point you to a really interesting paper that was published in Blood recently that looked at BCL-XL inhibition in patients with megakaryocytic leukemias and pure erythroid leukemias that may speak to a little bit of a different mechanism of action and responsiveness to those certain kinds of leukemias, but that's again only in mouse models, so not known for sure.
Thank you.
My pleasure.
Thank you, Sanjeev. We'll just take a few questions from the chat box. One question is, in a patient with TP53 mutation, is there a difference if you treat them with AZA plus Ven versus only AZA?
I have not seen the P53 patients broken out from the Viali A study to see if there was even enough patients to know the difference. But you could look at the molecular paper that Courtney published in Blood of 2020 and see if you could pull out that difference. I don't think there's a number to know specifically if there was a potential benefit in that subgroup. I can look and email you, Dr. Agarwal, if I'll pull up my paper at some point.
Sure, thank you. The other question is, in inversion 16 AML, young fit male, what will be the preferred induction regimen and how will you monitor?
A young fit male with inversion 16, I would give cytarabine, daunorubicin, and gemtuzumab, and I would consolidate with high-dose cytarabine.
Right. And monitor this patient with?
I would monitor this patient with periodic checks for the fusion protein for inversion 16.
Thank you. Another question is about maintenance therapy with oral azacitidine. Your recommendations?
Yeah, so I use that occasionally in patients who are in a nice remission but not going to transplant and who've gotten induction type of chemotherapy. I, at this point, do not switch people from aza-ven to oral aza. So because they're on continuous therapy versus on the maintenance, the only difference would be that it's 2 years of maintenance versus indefinite for the aza-ven. I have found that two of my patients who had CMML transformed to acute leukemia, who are able to get back into from acute leukemia back into CMML, those are patients that I've used oral AZA on. But it's occasionally I use it, but I only use it according to the package insert.
Thank you. There's a question about gemtuzumab. Besides a good cytogenetic AML, do you use it anywhere else?
So sometimes in a fit patient with, I think you could use it in a fit patient with intermediate risk cytogenetics who is an intermediate risk disease who is not FLT3 positive. So the meta-analysis showed a survival benefit to gemtuzumab in this, a very significant survival benefit in favorable risk karyotype, a less significant benefit in intermediate risk karyotype, but that intermediate risk karyotype did not include people that were FLT3 positive. I would separate out the FLT3 positive intermediate risk and treat them with a FLT3 inhibitor. Then if I have an intermediate risk group of patients that are otherwise fit, I think it would be very reasonable to use fractionated gemtuzumab like the ALPHA study in that group if you wanted to. There is a benefit, but I don't know if it falls out if you were to take that meta-analysis and remove the FLT3 positive patients.
Thank you. There's one more question related to gemtuzumab. Does it have a place in relapsed setting?
I occasionally have used gemtuzumab in an older patient that's CD33 positive that's refractory to aza-ven, but I haven't had very good success in it.
Right.
The other place I've used gemtuzumab is I've had a patient with APL relapse twice after arsenic and atra. So he was on his third treatment, third line of treatment, had terrible neuropathy. So I gave him gemtuzumab, which, knock on wood, has worked so far.
Thank you. The question about, is there any cutoff WBC count to start IDH inhibitor? Anything to give to prevent differentiation syndrome?
Yeah, so that's a great question. I don't remember from the clinical trial methods about what the cutoff was. I would have to go back and look at the protocol. And that's one of the reasons I pointed out that if it's published in New England Journal or Blood nowadays, the supplementary material includes the protocol. So you can look and see what was the treatment, what was the cutoff there. And I think that's really helpful. I generally get uncomfortable about patients with a white count of 50, 60, 70,000 to start an IDH inhibitor because I'm exactly worried about differentiation. So I will cytoreduce those people with Hydrea for a while, or even give them some low-dose Ara-C or some infusional cytarabine. I like to get their white count down to, below 10,000, below 15,000 or something before I give them a IDH inhibitor. In terms of prevention from differentiation syndrome, the most important thing I think is awareness, weight gain, fluid accumulation, crackles in the lungs. Those can all be a rash. Those can all be signs of differentiation that you have to be careful about.
Thank you.
Oh, and you treat with steroids and holding the drug, like you would for Atra.
In the salvage setting, is CLAG better than FLAG?
I don't know the answer to that. I don't think any of us know the answer to that. We happen to use CLAG. Right now, there's a shortage of fludarabine in the US. I don't know if that's the case here. So all the fludarabine's being saved for CART therapy and for transplants. So we use CLAG. I don't know that it's been compared 1-to-1. There's good data on FLAG. There's good data on FLAG-IDA in a relapsed younger patient. There's also FLAG-IDA-Ven, which is looking very good and which I might use in some young people as well.
Thank you. Is there any specific treatment for gilteritinib-induced hepatic toxicity for a FLT3 positive relapsed AML?
In my experience, the hepatic toxicity often gets better with holding the drug. The problem is that then the disease can come back also. So I do think you just need to, you can't continue to give the drug if the LFTs are, 2.5 times, 3 times normal, or the Billy's up. So you just have to hold it. Make sure you look for other causes. Of course, you want to be, make sure you know exactly what your patient's taking, that there's no over the counters or any kind of herbal supplements that they're taking that also could affect the liver. I've stopped people's cholesterol medicines. I've stopped people's antifungals at times because of this. And then you just have to hope it gets better.
Thank you. The question is about cytarabine dose in HIDAC if you are joining it with a targetable agent.
If I remember correctly, and again, you'd have to check me on the Ratify study, but the consolidation was 3 grams per meter squared in combination with the midostaurin. I think that's safe. I'm not sure it's necessary. I sometimes give 2 grams per meter squared, depending on the age of the patient. I've sometimes even given 1.5 grams per meter squared for 6 doses. So I kind of adjust. I don't think we know for sure that the dose of the cytarabine matters, and except that it needs to, the old CLAGB data said it was better than that 6 doses for 3 or 4 cycles in favorable risk was much better than, for example, infusional cytarabine. But the difference between 1.5 and 3 in an older patient, I don't think makes a difference.
Thank you. This one question about that. There are a small number of patients who respond to azacitidine alone, while more respond to azacitidine plus venetoclax. So do we know who respond to azacitidine alone?
I think the numbers for complete remission for azacitidine alone are so small that the predictive markers couldn't be derived, but the chances are low. Again, best case 12 to 17% complete remission rates. If you can change that to 66%, you should. So I really argue with patients that we can manage toxicities, but this combination is much more effective.
Sure. Dr. Saikat Datta, you have another question? And Dr. Sanjeev, yeah, Dr. Saikat Datta.
No, sir, thank you.
No, okay, Dr. Sanjeev?
No, sir, I don't have.
So I think that's the end of it. Dr. Laura, thank you very much. Fantastic lecture and a very long question answer session, and you answered everything so beautifully to the satisfaction of everybody from the data available and your experience. It was fantastic.
Oh, it's such a joy to be with you all. I'm very impressed and honored to be here, and what you're doing, reaching these people is really remarkable. So thank you so much. The Mumbai Hematology Group is now the International Hematology Group. So you should be very proud, and I'm thrilled to be here. Thank you so much.
Thank you so much. And I'm going to write an email to you. We will try to bring you to
okay.
this year itself.
That would be great. Thank you all. I appreciate it. Bye-bye.
A wonderful day. And thanks to everybody over here. We have our Prashant Agarwal for the official vote of thanks.
Thank you once again, Dr. and Professor M.B. Agarwal, sir, and eminent speaker, Dr. Laura. And thank you all the panelists and the participants for asking the very good questions. And I really thank Dr. Laura for giving us the answers for these questions patiently. It was a wonderful session, wonderful presentation, and good evening to all of you.
Thank you, Prashant, and thanks to Adley for supporting our academic activities continuously for last 3-4 years. We are grateful to you.
Thank you. We are pleased for you.
Have a wonderful dinner with your family. And then Amit, see you next week. Okay. Bye-bye.
Bye-bye.